So what view is this and what are our findings? Yeah, and it's doing that thing that gives you pause, right? When your anatomy becomes abnormal, your shot does not look classic, and it can sometimes give you pause and say, like, wait, what view is that? So, yeah, very dilated LV. If you were standing inside of this, you would feel quite comfortable. One day, I'm going to make that slide. That's the trash compactor scene from Star Wars. You know, the walls coming together and they're getting squished. That's what I want to go in one of these presentations.
What's the shadows inside?
Hyperechoic stuff. I don't know for sure. I mean, it's endocardium of some kind. So is it looking like that because it's papillary muscles that just aren't where they normally supposed to be? I don't know. I know it was a kid with a previously structurally normal heart who had viral myocarditis. Mm-hmm. Now, that's people will remark on that. They'll do the cardiac views, and one of the things that jumps out at them is they'll look behind the heart and say, "Oh, look at those B lines." I would caution you that it's something you can see often in healthy people also. And I don't know exactly why the cardiac views like tease it out, and then you go to the lung views with a linear probe and you don't see a bunch of B lines. But I kind of shy away from being definitive about, and we're going to have pulmonary edema based on the cardiac shots. Yeah, very plethoric IVC with, yeah, one of those features that when things really do get backed up and you've got a high CVP, you'll see the hepatic vein get very dilated and act like a big wedge within the liver. And this makes sense, right? My problem is my left side is not pumping, so everything back in the circuit is going to be dilated. What about my right and left upper quadrant views? Do I see any pleural effusion? Just in this static shot. Here's my spine. No extension, right? I wouldn't be surprised if I did see them. Pleural effusions are super common in people with CHF, right? And then, as it says up here, right lung axillary. What are the findings in these lung shots? Lots of V lines, right? The sonographic equivalent to crackles. Does this change your thinking in any way from my problem is left ventricular failure? Matches perfectly, right? So nothing to divert you. This febrile kid with shock would seem to have. Yeah. It doesn't always mean that they have viral myocarditis, which is what this kid had, because you know that you can get cardiac dysfunction. Just like you can get shock lung in sepsis, you can get shock heart. They might just have a myocardial dysfunction from disseminated sepsis. But we know that the startling finding for them is a big dilated LV. Okay, for the last bit, we're going to switch things up. We're going to make it more adult style. So our patient gets much older and changes gender. It's now a female who is 17 years old and has a fairly acute history of abdominal pain and looks quite unwell. They're not febrile, but they are shocky. And again, I keep putting the SAT at a spot that's supposed to make you feel like you can't read one way or the other into it. No, it's not stunningly normal. It's not really abnormal. Okay, so what do you guys think about now that we've changed the demographics that you might do differently in terms of the things you think could cause the shock and the views you might do or prioritize doing? Yeah, you're fast for intra-abdominal hemorrhage. Why? Yeah, ruptured ectopic. Beautiful. Okay, so let's start in our sort of, and I'm not saying you have to apply this routine the way that I'm applying things. I'm often showing you a subxiphoid first, and then a parasternal long, and I'm doing everything with like the low frequency probe before we switch to the high frequency probe. You can do things in whatever order you guys think makes the most sense. And there is this ongoing debate about, even in the FAST exam, what order do we do things in? With some people saying you use the linear probe first for tension pneumothorax. That'll kill you fastest. I want to know about that before I want to know about pericardial effusion. That's the second thing I want to know about. And the third thing I want to know about is intra-abdominal free fluid, just for that stratification of like how much time do I have with each of those conditions. But we'll start in this case with a cardiac view. Does anyone see a pericardial effusion? What about in the parasternal long? Any abnormalities? Okay. What about in this IVC view? Is that a plethoric IVC? Is it small, or is it somewhere in between small and, yeah, small. Okay. So we've got a small IVC, but a normal function and no effusion. And like Michelle said, we'll do our fast view, and like Nir says, there is indeed free fluid in Morrison's pouch. And so we'll go and we'll do a pelvic view as part of our fast. And what's this structure here that I'm circling? Sorry?
Ovary?
So try one more time. Uterus, I hear. Yeah. You see the endometrial stripe within? And this oval appearance of the fundus. And it comes down to making the corner of the cervix down here. Now, it is a little unfair because while you guys were watching the clip, an ovary did come into view. So the person's moving their probe back and forth laterally. And as they do that, there's an ovary. And there's the free fluid behind your uterus. So, you know, this is a patient, it's all about the timing of your system too. If you work in a busy adult emergency room, then this patient probably has a beta HCG resulted before they've made it from the waiting room into the main part of the ED, right? I mean, if they look really shocky, they'll get rushed back more quickly, and then you might see them before those nursing interventions are done. And you guys will encounter this in sepsis alert patients and shocky patients. Those are the rare times where like the doc gets called to the room before everything's done, right? The patient isn't on monitors, they don't have an IV in yet. And being a POCUS user and being like, I can answer these questions quickly, can put you at a little bit of tension with the team, where the nurses are at the right side of the bed also, and they're trying to do their things. And you're there with this big bulky machine, putting gel on the spots where they're trying to put monitor leads, or pulling off their monitor leads so you can put gel on those spots. And so there is the need sometimes to be, if you really believe that your POCUS can alter things, to be a little assertive, friendly assertive about what you're doing has as much or more value as what the rest of the team is about to do. And a lot of just 1 second, I'll be out of your way in 1 second kind of things can be useful. Because the few times that I've had ruptured ectopics, you know, people will sometimes say, oh, I wonder what the beta is going to be. And it's like, oh yeah, on this severely hypovolemic patient who's making no urine. So you can get a blood beta, right? But it takes a long time. There are little shortcuts you can take. You can take a urine beta pregnancy kit and you can put a drop of blood on it. And sometimes you'll get your answer that way much more quickly. Sometimes if you put too much blood on it, it obscures your ability to see the positive result. But let's say you do have these appearances. So you've got intra-abdominal free fluid. Right now you don't know the beta is positive. You can be fairly sure about what's going on, but not 100% sure. What if the beta now results as positive? If you want to talk to consultants about the probability that this patient with a positive beta and free fluid in a fast has a ruptured ectopic, what's the specificity of your assertion? Reproductive age female, positive fast, positive beta.
Knowing or from guessing?
From guessing.
From guessing? Pretty high.
Yeah. It's so close to 100 that you can pretty much count it as 100. You can count it as 100 for what needs to happen next, which is they need an exploratory laparotomy. And so, of course, these things that we quote as like 100%, this is a 100% thing, you can be totally confident. Then actual POCUS users will go and encounter cases where that isn't true. So I feel comfortable telling this story because the person this story belongs to has posted it on Facebook and talks about it all the time. But my old program director, Alex Arroyo, and his partner knew they were pregnant, and she developed acute abdominal pain while they were on vacation from New York to Philadelphia, and looked gray and felt terribly nauseated and syncopized. Right. And so he rushed her in his car to the closest emergency room. And if you ever meet Alex, you'll be able to imagine these next steps happening, where he found the ultrasound machine. And while people were like, "Sir, what are you doing?" And he was like, "Get out my way." He finds the positive fast in her, and so he's like, "Okay, this is a ruptured ectopic. Damn it." And then, lo and behold, she does go for her exploratory laparotomy and has a giant hemorrhagic ovarian cyst, and not a ruptured ectopic. So there are always these possibilities. Their child from that pregnancy, Grayson, is a healthy, super cute little kid. But you can be very certain about the need for therapeutic intervention. The fact that 0.1% will end up being a hemorrhagic cyst doesn't really change the fact of what needs to happen next.